The following presentation is regarding bowel obstructions for a group of Concepts 2 students during the Concept Elimination GI. Bowel obstructions are considered a complication of Elimination GI and not specifically an exemplar. There's 3 different causes of bowel obstructions. The first cause is a mechanical cause that's due to tumors or adhesions. Adhesions are fibrous bands of tissue that abnormally hold structures together. Tumors and adhesions decrease the intestine's ability to function with normal bowel motility. Vascular can be a side effect of a mesenteric inclusion. So your mesentery supplies blood to your intestines. If you have a mesenteric occlusion and blood is not supplied to the intestines, part of the intestines can die, causing a bowel obstruction because there is decreased GI motility in that section of the bowel. The third cause is a neurological cause, which is most often called an ileus. A post-surgical ileus or a paralytic ileus is when the bowel is not innervated to move. Often this happens after general anesthesia and or major abdominal surgeries. Clinical manifestations. So for a small bowel, you're going to have visible peristaltic waves. You can actually see the bowel trying to move. There will be abdominal distension, which is the cause of the abdominal distension is the inability for air to pass through the intestine and out of the abdominal cavity. Therefore, when you percuss a distended bowel due to a bowel obstruction, you will hear tympany. Nausea early with profuse vomiting. Often, once patients report to the emergency room or admitted to a unit for a bowel obstruction, their nausea, their vomiting has stopped. They're still nauseous, but there's actually no stomach contents for them to vomit. Obstipation or no stools. If you have a blockage in your small intestine, the food or the chyme is not able to pass, therefore you're not able to make stools. So after the stool has been evacuated that's in the large bowel, patients will then not have any stool. Fluid and electrolyte imbalances. So patients that are vomiting large amounts of emesis will have metatabolic alkalosis because the stomach contents are very acidic. Additionally, our patients will suffer from hypokalemia as well as fluid volume deficit. Large bowel obstructions, patients will have cramping, distension, minimal or no vomiting, and the minimal or no vomiting, if they do vomit, it may be fecal material. Ribbon-like stools. We often see ribbon-like stools when the cause of the bowel obstruction is a tumor in the large bowel. What's happening is the stool is kind of squeaking past the tumor, and patients unable to have a formed stool. It looks more like a ribbon. And then metabolic acidosis. When patients have metabolic acidosis due to a large bowel obstruction, if you remember from our lecture about pancreatitis, your pancreas is responsible for providing the base in your intestinal tract. If you also remember, anytime you put something into your mouth, your pancreas begins to make those enzymes and release them. Excuse me. If your patient's been NPO, their pancreas will not be signaled to release the base, therefore causing an increase in the acidic content within the stomach due to the inability for neutralization. Intestinal obstructions diagnostic testing. We often will do abdominal x-rays to look to see if there is trapped air, can signal that a patient has a bowel obstruction. Abdominal x-rays are non-invasive, but you have to worry about the amount of exposure over time. CT scans will also show us adhesions as well as potential mesenteric inclusions. A barium enema or a colonoscopy would be able to identify if there is a tumor that's blocking the intestinal tract. Health history that's important for patients with a bowel obstruction. Medication. So we want to look at those medications that either decreased GI motility or those medications which cause constipation. Historically, narcotics and iron supplements will cause constipation. A history of abdominal surgery or radiation therapy will allow adhesions to be formed. Additionally, inflammatory bowel disease will allow adhesions to be formed within the bowel. Hernias and tumors can also cause a mechanical obstruction. Patients can have something called an strangulated hernia, where the muscle fibers separate and the intestine is allowed to poke through the through the muscle layer. It then gets twisted, and that twisting of the bowel causes an obstruction. Diet history: patients that have a low roughage diet, or also a diet that's high in red meat, can cause constipation, as well as diets that lack fiber and water. Recent occurrence of nausea and vomiting. Patients that have had nausea and vomiting within the past month, and it has resolved on their own, is often a sign that they may have started to have a bowel obstruction, and then intestinal motility returned. You want to know the last time of their bowel movement. Change the time of the last bowel movement, if it's been days, if it's been months, if it's been hours. Change in bowel habits or stool and blood are also important. And then a family history of colorectal cancer, because colorectal cancer is genetically linked. So, nursing process. First, assessment. We will identify the cause and the location of the obstruction. So, using the clinical manifestations from the slides above, you would identify if the bowel obstruction, if it's a large bowel obstruction or a small bowel obstruction. Also identifying if the patient has past medical history, or if they have a tumor in their abdomen, or potentially post-surgical patients. The plan here is to decrease pain, hydration, fluid electrolyte balance, and stomach decompression. I'm sure your nurse brains are already thinking about how you achieve those goals. So, pain management. You have to be careful with pain management in our patients that have bowel obstructions, because narcotics tend to decrease GI motility. So we often give these patients Toradol, which is a IV form of an NSAID, if it's not contraindicated. If Toradol is given for greater than 5 days at a time, it can increase the patient's risk for bleeding. So if patients have other risk factors for bleeding, Toradol may not be appropriate for them. Narcotics are given in very small doses due to the decreased ability for GI motility. Position of comfort. Often patients find the fetal position comfortable, or their knees to their chest comfortable, because it reduces the stress and the pull in the abdominal muscles. Hydration. Once again, this is where you want to look at, is my patient actively vomiting and hypotensive and tachycardic, and I need to replace fluids, or is my patient NPO and I need to give maintenance fluids? And that will greatly depend on the patient's blood pressure and heart rate. Electrolyte replacement. So if I have a patient that has an NG tube in and it's sucking out all of their gastric contents and they've been vomiting, the electrolyte that may need to be replaced is their potassium. Please remember these patients are NPO, so potassium will be given intravenously. An additional complication to administering potassium intravenously is the idea that a patient may need to be hydrated and get potassium at the same time. In this case, additional potassium may be added to liters of IV fluid. In our patients that have a neurologic ileus, or a post-operative ileus, or a paralytic ileus, we may choose to give a medication which increases GI motility. The medication that increases GI motility is Reglan. The only type of bowel obstruction where this medication is indicated is a neurologic ileus. Patients that have a mesenteric occlusion and patients that have a mechanical obstruction are not candidates for Reglan. And then we have a nasogastric tube. Patients will have an NG tube placed if they need to have their stomach decompressed. Most patients that have bowel obstructions will have an NG tube. It is a common nursing intervention. Please remember and review evidence-based practice, how we identify the tube is in the right place. additionally what electrolytes will be replaced and what measures we take to prevent aspiration pneumonia in these patients. Thank you.